Jumping into the wrist, essentially the protocol here is going to be two axial sequences. One is going to be non-fat saturated, which will be better to take a look at the anatomical structures, mainly the bones, taking a look to see if there are any osteophytes, abnormal marrow signal abnormalities, and then a fluid sensitive fat saturated sequence. And then you're going to get kind of a similar thing for both coronal sequences, and then you will also have a sagittal sequence as well, which we will get a little bit more into near the end of this video. So what I like doing is I'll start with the coronal T1, and I'm really just kind of taking a broad overview, looking at all of the bones, the distal radius, the ulna, take a look at the scaphoid, lunate, triquetrum, pisiform, as well as the additional carpal bones and basis of the metacarpals to see if anything catches your eye, or to evaluate the degree of degenerative changes if there is prominent osteophytosis. Then I'll essentially do the same thing on the fluid sensitive, taking a look at all the osseous structures to see if there's any marrow edema that'll kind of catch my eye. Common pathologies being evaluation for a scaphoid fracture and degenerative changes involving the carpal bones, generally at the triscaphe joint or at the first carpal metacarpal joint. And then after that, I'll start to run a lot of the soft tissue structures of the wrist. The first of those being the scapholunate ligament. So this is a ligament that's technically going to have a more volar, a more central, and a more dorsal portion, depending on how the MR turns out. A lot of times I feel like it is difficult to denote one part of the component from the other different parts of the component. So a lot of times I kind of just lump it together as just kind of one discrete structure. And as you can see here where my cursor is, this is kind of where your scapholunate ligament is going to be. It's grossly intact in this case. Sometimes you may see a little bit of signal alteration or a higher degree of signal, which may suggest that there's degeneration or partial thickness tearing. If you don't see it at all, that's going to be something that denotes that there's a full thickness tear of the scapholunate ligament. And now we're going to do a similar thing with the lunotriquetral ligament, which looks really normal in this case. So this is going to be your lunate, this is going to be a triquetrum, and this is going to be where the ligament lies. This is our lunotriquetral ligament, which you can see is intact here as well. And then the next structure we're going to talk about is the triangular fibrocartilage. So the triangular fibrocartilage is actually just one component of several additional components that actually make up what we call the triangular fibrocartilage complex. In addition to the triangular fibrocartilage, you're going to have dorsal and volar radioulnar ligaments. There's going to be the meniscus homologue. There's going to be the ulnar collateral ligament and the extensor carpi ulnaris tendon. Usually out of all of these structures, the most common pathologies are going to be the triangular fibrocartilage itself, and then the extensor carpi ulnaris tendon, which we'll better evaluate on the axial sequence when we get there. So looking at the triangular fibrocartilage, you can divide this into multiple different components, the main ones being this central disc here. A common pitfall is misinterpreting this kind of interface with the adjacent radial cartilage as an abnormality, but this is just what the normal interface looks like for the triangular fibrocartilage. A lot of the abnormalities with this central disc are going to be kind of pinhole tears or abnormal signal denoting degeneration throughout this kind of more central portion. Then as you kind of come over here more peripherally, you're going to have two attachments, one going to the fovea of the ulna and the other going to the ulnar styloid process. And in this case, they both look intact. There's not a lot of increased signal. The triangular fibrocartilage honestly looks pretty good in this case. In addition to that, I will kind of gestalt looking around the entire kind of joint to see if there are any obvious cystic areas that could suggest that there's ganglion cyst formation, which is another source of common pathology in the wrist. After we finish looking at the structures on the coronal sequence, we're going to come into the axial T1. This is going to be kind of more helpful to evaluate the median and ulnar nerve. The median nerve you can see is this kind of bundle right here where my cursor is, and it'll be deep to the overlying flexor retinaculum. So you want to look for preservation of the actual kind of fascicular pattern of the nerve. It's not abnormally thickened, it's not abnormally flattened, and there's no signal alteration associated with it. One of the things that can suggest that there's median nerve pathology, and suggests carpal tunnel syndrome is bowing of the flexor retinaculum. This is the flexor retinaculum right here. If you imagine you draw a line across from here, and then you have bowing of the retinaculum, you're going to draw another line down, and you're going to measure the degree of displacement of that flexor retinaculum to suggest whether there is carpal tunnel syndrome or not. Outside of the median nerve, the ulnar nerve is going to kind of be more on the ulnar side here, kind of in this bundle. And I just take a quick look just to make sure that it's not grossly thickened and there's not a lot of signal abnormality associated with it. Outside of that, you can take another look at all of the bones here just to make sure there's no fracture, large osteophytes, or anything else that may catch your eye. It also is very easy to denote Lister's tubercle here, which we'll get into a little bit more detail on the fluid sensitive sequence, which is what we're going to come to now. So there's going to be an entire assessment of all of these different extensor compartments, and it's going to be important to denote one extensor compartment from the others. And so what you do is you're going to kind of use the Lister's tubercle as kind of a landmark to denote the third extensor compartment from the second extensor compartment. So the third extensor compartment is going to be your extensor pollicis longus, and you can think of it as being, it has a long way to travel over to the thumb, and it'll kind of pass over the top of the second extensor compartment, which is going to be these kind of two tendons here. So these are going to be your extensor carpi radialis tendons, and kind of an easy way to remember which one is brevis, which one is longus, is just as long as you know which one is the third compartment. So in the third compartment, if this is longus, it alternates as it goes all the way across to the first compartment. So extensor pollicis longus, this is going to be brevis, this is going to be longus, then your next tendon will be a brevis, and then the next tendon will be a longus. So this is extensor pollicis longus, this is extensor carpi radialis brevis, this is extensor carpi radialis longus, and then you're going to get into extensor pollicis brevis, and then your last one is going to be your abductor pollicis longus. So the second compartment are the extensor carpi radialis tendons, and then in the first compartment you're going to have an extensor and an abductor, which are a part of the first extensor compartment. Common pathologies are going to be tenosynovitis or circumferential fluid involving the first extensor compartment, which is what we call dequervain tenosynovitis. The other common thing is as the third extensor goes over the second extensor compartment, you can get fluid in both of the tendon sheets as they're rubbing against each other, and this is what we refer to as intersection syndrome. So now going the opposite way, if this was 1, 2, and 3, your extensor compartment 4, which you can see there's a bunch of small tendons here, are collectively referred to as the extensor indices. And then your fifth extensor compartment is going to be next to that as you go over. This is going to be your extensor digiti minimi. And then your sixth extensor compartment is going to be your extensor carpi ulnaris, which we previously mentioned is a portion of that triangular fibrocartilage complex. So this can be another source of commonly explained pain if you have tendinosis. So you're looking for abnormal thickening. Is there increased signal? To the degree of, is there even interstitial tearing of that tendon as well? And you see it kind of rests on what appears to be a groove. Sometimes you can even get subluxation or dislocation of this tendon from that groove. So just make sure it's anatomically positioned. The other common sites in the body where you have tendons that are prone to subluxation and dislocation is going to be the long head of bicep tendon near the shoulder, where it can pop out of the bicipital groove, and then the peroneal tendons in the ankle can also become subluxed or dislocated. In this case, this is not abnormally thickened. There's not a lot of signal. It is appropriately positioned within its groove, so there's no pathology with the extensor carpi ulnaris tendon. We talked about the signal alteration for the median nerve. This really doesn't have a lot of signal alteration. It's not overtly thickened, and there's no overt bowing of that flexor retinaculum, so that all looks okay. The other thing that this can be helpful for is troubleshooting a location for a ganglion cyst. So a ganglion cyst should be a cystic structure that has a neck that communicates with an adjacent joint space. So this can kind of be helpful for, is it more dorsal? Is it more volar? Is it on the more radial side? Is it on the more ulnar side? And then the last sequence that's going to be really important here is going to be this sagittal sequence right here. This is more for an alignment type thing where you're looking at the lunate and you're making sure there's no abnormal dorsal or volar tilt. If there's abnormal dorsal tilt of the lunate, that's something you can see with dorsal intercalated segmental instability or a DC deformity. And this usually goes hand in hand with a tear of the scapholunate ligament. And the opposite would be if there's volar tilt of the lunate, which would suggest volar intercalated segmental instability, which would suggest an abnormality, or goes hand in hand with tears of the lunotriquetral ligament. The other kind of big constellation of findings that we commonly can see in the wrist is when you get full thickness tearing of the scapholunate ligament and widening of the scapholunate interval in conjunction with proximal migration of the lunate and secondary developing degenerative changes of the radiocarpal joint. And this is all part of what we call scapholunate advanced collapse or slack wrist. The other thing to look for on this sagittal here, a common pitfall is overcalling what appear to be ganglion cysts on some of the other sequences, but is just joint fluid recessing next to the pisiform. This also can be helpful to look along the kind of the more dorsal and volar aspects to kind of localize ganglion cysts as well. The last sequence, which may be institutional dependent, will be this kind of more smoother scrolling kind of sequence here, where it can kind of more easily denote kind of the boundaries of the cartilage around all the bones. I feel like this is helpful in inflammatory arthropathy cases where you're looking for more subtle erosions and cystic change in the bones. And some of the other things you'll look for is blunting of the ulnar styloid process. This also can make it easier to see mineralization, so potentially if there's chondrocalcinosis of the wrist, it'll stand out more on this sequence as well.